Hello, everyone, and thank you for joining today's webinar, Health and Healthcare in Autistic Children and Adults. Before we get started, I'd like to go over a few housekeeping items so you know how to participate in today's event. To the right of your screen is the control panel, and as an attendee, you have the option of listening in using your computer speaker or your phone. To switch between the two, just select phone call in the audio pane and follow the dial-in instructions. If you're having any trouble hearing me, please send a message through your questions pane and we will assist you. For today's session, we've also shared some materials located in the handouts panel. You can download these materials at any time. We cannot answer any clinically relevant questions for specific individuals, so please phrase your questions in a way that does not involve particular children. At the end of the presentation, we will email a certificate of attendance that you'll be able to download. Since your mic is muted, you can submit your questions to your presenter by typing those questions into the questions pane at any time. We will hold off on answering any questions until the end of today's presentation. Since most of you are now here, let's get started. We're now going to begin the recorded portion of today's webinar. For those of you who just joined us, good afternoon and welcome to today's webinar, Health and Healthcare in Autistic Children and Adults. My name is Kathleen Hughes and I'm your host for today's event. It's great to have you all here today. I have the distinct pleasure of introducing today's speaker, Dr. Jessica Rast. Dr. Jessica Rast is a researcher at the AJ Drexel Autism Institute of Drexel University. In her role, she catalogs and analyzes existing national data sources to present a national picture of experiences across life domains and the lifespan. Much of her work focuses on the transition period from adolescence to adulthood. She is particularly interested in healthcare, and models of health service provision, including examining ways primary care can facilitate mental health care in autistic children and adults. So without further ado, I'll turn it over to Dr. Jessica Rast. Dr. Jessica, take it away.
Thank you so much. And thank you everybody for attending today. I'm really looking forward to speaking to you about this topic, and hopefully we can all have some fun learning going on. Okay, so I'll be talking, as she said, about health and healthcare in autistic children and adults. I want to start, there we go, with just a quick note on language. So throughout this presentation, I'm going to try to show preference for the term autistic when talking about autistic people, but you'll notice in a lot of the graphs I present, ASD or autism shows up. It's sort of an artifact of some of the research we were using and also some of the surveys that we used to get this information from. I just also want to point out this current commentary and from the journal Autism in Adulthood that was on language. And it was specifically about the importance of language as it relates to ableism. So that's a really interesting piece that I suggest you check out if you're interested. All right, so a quick overview of what I'm going to talk about today. I'm going to talk about health as an integral part of quality of life and try to convince you all of the same. So then I'll also go over how we studied health and how we study healthcare. I'll present findings on a few health topics. There are a lot of topics related to health, and I do not have time to cover nearly a portion of them today, but I'll talk through a few of those that I think are important to highlight in this context. And then finally end with some final thoughts on what we can do about all the findings I present today. Okay, so why focus on health? Health is an integral part of quality of life. Good health impacts everything we do, although we don't maybe think about it when it's there. But certainly when health is poor, we recognize the persistent role it plays in impacting every part of our lives. So then why focus on healthcare? Well, healthcare impacts health by impacting what types of services we can receive and from whom and when. Health policies and insurance impact our healthcare. And health services and reimbursement patterns are not really optimized to provide the comprehensive care that we know autistic children and adults need. There's also been a bit of a boost in national attention on this issue and on health and healthcare. So this past year, the Health Health Resources and Service Administration reinvested in the Autism Intervention Research Network on Physical Health, or the ARP. The Autism Cares Act of 2019 requires a report be submitted to Congress on the health and well-being of autistic people. The Interagency Autism Coordinating Committee, which sits in the U.S. Department of Health and Human Services, recently convened a subcommittee to address health needs of autistic people. And there's a growing body of national research that pays attention to these topics as well and really identifies the importance of them. And then more on an individual level, a focus on health is important in autistic people because we know that they can have really complex health needs. There is some suggestion that they may use care more often and more care than their peers and may have higher healthcare costs. Things like emergency department visits and other types of hospitalizations may occur more often. And even when autistic people do access the care they need, they often report more unmet needs. So there's additional care that they should have received but weren't able to. And then, so a little more context on health at a bit of a higher level. So we know there's a lot that influences health and healthcare. So there's social and political factors that influence healthcare and health services and what type of care people can receive. And then there's factors like disability and race and ethnicity that impact health and healthcare. A lot of our work uses the life course perspective to study a lot of the outcomes we look at. And the life course perspective tells us that as things progress through the life course, we have different needs throughout our life, and things that happen earlier in life, health-related, health service-related, can impact our health trajectory long-term. So we can set ourselves up for great success or more challenges depending on how we were able to access services and treat our health as younger people. And then there's also some systematic differences between these time points in life. Particularly, one of the things I focus on is this big difference between pediatric healthcare and adult healthcare. But there's other points in life where this may be true. Into older adulthood, this also may be true over certain periods of time. For example, this international pandemic we have right now is an example of differences in care that might occur across a life course. So a lot of the information I'm presenting today comes from our most recent report. We published this report in November, the National Autism Indicators Report on Health and Healthcare. So this is maybe the 6th or 7th report in our series where we present these national level indicators. And the purpose of this is really to catalog healthcare and autistic people across the lifespan with the aim of highlighting inadequacies in the current care systems, as well as supporting recommendations for improvement at the practice level and at the policy level and programmatically as well. Okay, so after that little bit of introduction, here is what I'm going to talk about today. So these are some of the health topics that I want to cover. I think that this gives a good introduction to the whole topic of health, although there are so many more aspects of health that are important to consider, but these are some of the ones that we focused on and are trying to do some things to move the field forward and to make some real strides in health and healthcare. So first I'm going to talk about accessing services, then healthcare transition, race and ethnicity health disparities, primary care gaps, and then how do we think about providing better primary care to autistic people? And then one more note before I start. Throughout these results, you'll see this comparison to children with special healthcare needs. Special healthcare needs is a designation that notes if children use or need more healthcare than is typical for children of that age. It's not tied to a specific health or behavioral health condition, but many children who have a health or behavioral health condition will qualify as being a child with special healthcare needs. So I just want to point this out as a concept that will be a point of comparison for us. And I don't really have any points of comparison to add for adults because those are a little bit more self-explanatory as we go through. All right, so we'll start with accessing services. So the first thing we'll look at here is the rate of healthcare visits for children, autistic children. So the top line here is autistic children in green. So we see that 95% of autistic children had some sort of office-based visit in the past year. This is a little bit higher than children with special healthcare needs, which is down there at 88%, which is also higher than children with no special healthcare needs. But the biggest difference that I want to point out on this slide is that the average number of visits per year for autistic children is 29, which is much higher than children with special healthcare needs, which is down there at 9 visits. I might try to turn on my pointer. Nice. Okay, so another aspect of expenditure of healthcare visits is expenditures. So up here in the top row, we can see expenditures for autistic children. So the out-of-pocket expenditures, which are things like copays and other payments that the family makes, for the average for children, autistic children in a given year was $750. So it's almost $300 more than children with special healthcare needs, which is more than children with no special healthcare needs. When we look on the right here, we see the average total expenditure, which includes all of the insurance payments as well. So again, we see higher expenditures, total expenditures for autistic children than we do for their peers. So then there are a few aspects of healthcare that challenges sort of the usual healthcare system and paradigm for children with autism. So we see high rates of co-occurring conditions. We see a need for mental health care and prescription management surrounding the mental health care. We see lack of accommodations at offices for autistic patients. And then there's also this noted difficulty of provider-patient communication, especially around complex healthcare needs, which are evident. Okay, so we'll start with co-occurring conditions for children. On the left here, we have autistic children in these blue bars. So the most common co-occurring conditions for autistic children are learning disability and developmental delay. Right below that, we've got behavioral or conduct problems and speech and language disorder. And then we also see pretty high rates of ADHD and anxiety. And I want to point out that these are parent-reported conditions, so these aren't from medical records or from patient records or anything like that. This is the parent reporting that their child has this condition. I want to note that almost every one of these conditions, with the exception of asthma down here, is more common in autistic children than it is in children with special healthcare needs. So we've got high rates of co-occurring conditions here. Okay, and then next, this is a repeated graph. So this is the same thing, but this is transition age youth. So youth ages 15 to 25. I also want to note that this is a slightly different population. So these transition age youth are receiving care through the Kaiser Permanente Northern California healthcare system. And so that means these people are all in Northern California. But as I'll mention a little bit later on, we really don't have very much national level information about adults, healthcare and health outcomes of autistic adults. So we use some information from these more regional findings. The other difference between the previous slide is that these are from patient medical records, not from parent reports. So that's may explain some of the differences we see here in these prevalences. But when we look at autistic transition age youth on the left, the most common conditions here are weight related, so obesity and overweight. We also see high rates of ADHD and anxiety. And then the thing that's similar to the last slide is that every single condition, with the exception of musculoskeletal problems, are more common in autistic transition age youth than they are in peers without autism. And then finally, I also have some information about adults. So this is autistic adults receiving care again through the Kaiser system in Northern California. So autistic adults on the left, the most common condition, stomach and intestinal diseases, and then obesity is also very high on this list as well. I want to point out the high rates of anxiety and depression. And then similarly to the last two slides, all of these conditions, with the exception of asthma, are more common in autistic adults than they are in their peers without autism. I also want to point out these high rates of hypertension for autistic adults. So this is a really important concern because untreated hypertension can lead to a lot of health problems down the road. And the fact that we see these higher rates in autistic adults means that this is something we really need to pay attention to and provide care for within the primary context to make sure that we reduce any burden that may be associated with hypertension. So another component of healthcare is mental health care. So here we're looking at mental health care in children. The green bar on top, we see that almost half of autistic children had some sort of mental health treatment or counseling in the past year. And that rate was higher than children with special healthcare needs, which was about a third of children, and much higher than children with no special healthcare need. And another aspect of mental health care management is management of mental health medications. So here we're looking at psychotropic medication use. On the left, parents were asked if their child took medication for autism. We've broken it out by age here because medication use is more common in older children. So we wanted to sort of see this picture unfold. But 1/3 of older autistic children, so ages 12 to 17, we're using some kind of medication for autism. And then if we look over here on the right, parents were asked if their child took medication because of difficulties with emotion, concentration, or behavior. And half of parents reported that their autistic child is taking medication for that. And then we also have some information about adults for this. So these are those adults in the Northern California area. So this top row shows us that almost 2/3 of autistic adults took some type of psychotropic medication. And that is higher than adults with ADHD, which is about half, and then a much smaller portion of the general population. And then the most common were antidepressants, where almost 40% of autistic adults took an antidepressant. Okay, so we've presented on the fact that there's complex care, there's autism-specific health concerns that need to be addressed within care. And I'm about to show you that many, and particularly adult providers, are not adequately prepared to care for their autistic patients. So this is a survey of providers within the Kaiser system. Almost 1,000 providers were asked how they felt that they could care for their autistic patients and how their patients and their caregivers were equipped to help in their care. And so these are all adult providers. On the top, the providers were asked if they felt that their patients' caregivers had enough support to partner with them as providers to provide care. And then they were also asked if their patients themselves had adequate support to partner with them. And fewer than about a quarter agreed that that was true for both of those outcomes. A little bit less agreed that that was true for the patients than did for the patient's caregivers. But either way, the majority did not feel that the statement was true. And then when we look at the bottom row here, providers were asked if they had adequate tools to accommodate autistic people in their practice. And only 14% agreed with that in any way. So we see really low rates of preparation to adequately treat autistic patients. Okay, so then we'll move on to healthcare transition. So healthcare transition is the process of moving from pediatric to adult healthcare. There's a few key components of this. So one is that care ownership changes over this period. So in pediatric care, the provider is one of the main drivers of care along with parents. But in adult care, the patient themselves is supposed to take on the onus of managing their own care. There's also more logistic things like moving to adult providers, including primary providers and specialty providers. And there are also insurance changes. So how a person is insured and through what mechanism is very likely to change from childhood to adulthood. Best practice suggests that healthcare transition starts as early as age 12. And previous research has shown us that there are very low rates of formal transition for autistic children, even compared to other children with special healthcare needs. Okay, so on this slide, we're presenting some of the aspects of transition. And as you can see, some of these aspects are met more often than others. So at the top, the most commonly met aspect is that the parent reported that their provider worked with their child to make positive health choices. And then not too far behind, but a little lower, the provider working with their child to gain health skills. And then about half of parents reported that they knew how their child would be insured as an adult. Then these bottom three are below a third, so relatively few children are receiving these. The provider's not working with our child to understand the changes that happen at age 18. Their provider's not creating a written plan for transition, which can be really important, especially when there's a lot of health care aspects at play. And then if the provider only treats children, they had discussed a switch to an adult provider. I also want to point out that there's a big disparity in especially this component of healthcare transition. So the provider working with the child to gain health skills. This is really important to point out because we've been seeing so far that there's really complex healthcare needs for autistic children and they continue into adulthood. And so there's absolutely no reason that children shouldn't be working to understand their healthcare and understand learning how to manage their healthcare. We did see above that there's a lot of discomfort in provider ability to work with their autistic patients. And so I certainly believe that that feeds into this a bit. So maybe providers aren't sure exactly how to teach or what skills to teach to some of their autistic patients, but this is definitely something that needs to be addressed. And then the next aspect of transition is actual moving. So who do children see when they become autistic adults? This top graph here I just brought up from the slide I showed you before to remind us that there's such very low rates of provider feeling like they have adequate tools to accommodate people in their practices. From the same survey, we saw that no physicians received formal training in screening or diagnosis. And just as a reminder, this is only of physicians that are treating adults. And then when asked to rate their knowledge and skills for providing care to autistic patients, 77% rated their skills as poor or fair. And when you look further by provider type, 88% of OBGYN providers rated their knowledge as poor or fair. That's very concerning because autistic females obviously need help in the healthcare system as well, and there's special considerations and a lot more research needs to go into that, honestly. But OBGYN concerns are a real concern that many autistic women face, so that is a very high number. Okay. So then I want to show a few of our findings related to health inequities. So specifically by race and ethnicity, just as in traditional healthcare in the larger population, we see these disparities persist in differences in health and also differences in healthcare. And these are important to note and then drive forward doing something about these disparities. So first I want to point out disparities in health and health conditions. So when we're looking at co-occurring conditions, some of them are more common in children based on their race and ethnicity. ADHD and anxiety are the most common in white children who are non-Hispanic. And while asthma and developmental delay are much more common in Black non-Hispanic children than they are in other children. So we will look at this somewhat large graph here. So we've got, these are some of the most common co-occurring conditions, as I showed you several slides above. And I just want to point out here that we see these differences by race and ethnicity for all of these conditions. Over here on the right at the top, we have anxiety. So we see that half of parents of white non-Hispanic autistic children reported that their child had anxiety, compared to a third of Black children and even fewer children of another race, and slightly more children who are Hispanic. And the similar story is here for ADHD. But we see opposite patterns here when we look at learning disability and speech and language disorder. Those numbers are much higher in both Black children and Hispanic children than they are in white children, which is the first bar, or children of another race. And then we also see for developmental delay, that's the most commonly reported in Black non-Hispanic children. This is related to some findings that special education researchers see, where there's differential diagnosis or inclusion in special education categories based on race. It is often thought that Black children specifically are often misdiagnosed and included in categories other than autism, including potentially learning disability or developmental delay, and also conduct disorders. So this is sort of shadows those results and findings. And this is almost certainly a result of misdiagnosis and underdiagnosis of autism. And then I also want to point out the asthma findings. So a third of Black children have parent-reported asthma, which is twice as much as any other children. And asthma as a physical health condition has a lot of potential negative effects if it's not treated. So this is certainly a concerning finding, but not unexpected based on findings in the larger population. Okay, so then we also saw disparities in visits. This graph is showing the number or the percentage of children, autistic children, who saw a physician in the past year, stratified by the same racial and ethnic categories here. So Hispanic children were the least likely to have seen a provider in the past year. And then there's other components of care that are really important to consider when we're looking at access. So here we're looking at, on the left, having a usual source of preventive care. So nearly all white children and children of another race had a usual source of preventive care. And that is a much lower rate, or a lower rate in Hispanic children and in Black non-Hispanic children. In the middle, parents were asked if they had a usual source of sick care. So more like emergent care if the child needed to see a provider in a hurry. Again, we see this pattern where white children are the most likely to have this reported on their behalf, but here instead, Black children are the least likely to have this. And then the last component over here on the right is having a personal doctor or nurse. So we see that only about 2/3 of Hispanic children and Black children have a personal doctor or nurse, compared to 80% about for white children or children of another race. Okay. So then there's a few other points of care accessibility that we can examine, including paying for care. So half of Black families, or families of Black autistic children, reported that they had trouble paying for their child's medical care. And this was compared to between 1/4 and 1/3 of parents of other children. And then we can also examine aspects of care, including care coordination and referrals, which are really important aspects of accessing care. So here we do just that. On the left, we're looking at whether or not the parent needed help coordinating care. So parents of Black non-Hispanic autistic children are the most likely to report that they need help coordinating care. And actually Hispanic children are the least likely to have parents report need for help. And then in a very similar story over here, this is the need for referral. So, you know, sometimes referrals are necessary for new providers. They may be a requirement of insurance. But for whatever the reason, about half of parents of autistic Black children reported that they needed a referral in the past 12 months. And that was a larger percentage than families of other children with autism. Okay, so next we'll look at some primary care gaps. So we found high rates of unmet healthcare needs, and specifically we can talk about what those needs were. We have some information about preventive services, which is a really important part of primary care. And then we'll talk a little bit about the escalation of health problems. So when and why people end up receiving emergency care, including hospitalizations. There's a lot of conditions, or there are conditions for which a person ends up in emergency care that they could have avoided such care if they had adequate primary care. And so it's important to look at those types of conditions in relation to primary care to see what we can improve. Okay, so this is parents reporting their child had unmet healthcare needs. Of parents who reported that their child needed more care, which I think was about 20% of parents, half reported that their child needed mental health care. And so that was the most commonly reported needed service for autistic children. And that was more commonly reported in autistic children than it was for children with special healthcare needs or children with no special healthcare needs. And then the next most common reported need or unmet need was dental care. And then I will also point out at the bottom that there was about a quarter of parents of autistic children reported that their child needed some other type of service. And that's more common than for other children. So along with unmet need, there's also this component of need, which is effort to get services. So here we're looking at parent report frustration in their efforts to get services for their child. So just over half of parents of autistic children reported that they were frustrated at least sometimes in getting care for their child. This is a lot higher than children with special healthcare needs, where only about a third of parents reported frustration, and much higher than children with no special healthcare needs, where the norm was little frustration or no frustration to get services for their child. Okay, so then we'll move on next to look at preventive services. And as I said, this is a really important component of primary care. Hopefully, reducing more serious health consequences in the future by screening for them in the here and now. So the most common preventive service for autistic adults was flu vaccine. And again, these are the Kaiser findings. So a reminder that these are adults receiving care through Kaiser in Northern California. Some other screenings that were looked for was cholesterol screenings and diabetes screenings. These are lower percentages, but these are actually, all three of these are actually more common in autistic adults than they are in adults with ADHD, which is the comparison in this study, or a general population comparison. One possible reason for this, as we saw before, autistic adults and children access more healthcare. So maybe there were just more chances for them to interact with healthcare. So they had more chances to receive preventive care. When we look at men specifically, we see that the rate of prostate cancer screening was about 14%, which was the same as it was in peers. But then when we look down at women, we see a lower rate of cervical cancer screening in women, autistic women, than we see in other women. So this is concerning, but maybe not surprising, given the fact that before we discussed the finding that OBGYNs are particularly uncomfortable in their ability to provide care for their autistic patients. So their care ability is potentially impacting the type of care they're able to provide for their patients. And this is a concern that needs to be addressed. So then finally, we can look at inpatient hospitalizations. So hospitalizations for mental health concerns were common in both children and adults. And there were also these conditions that I alluded to before that should be treated within primary care and therefore keep a person out of the hospital. And these are referred to as ambulatory care sensitive conditions. So it's a busy slide. We've got the top 10 reasons for hospital admission in autistic patients. So on the left, we have children, and then on the right, there's adults. So first, I'll just point out that the most common reason for hospitalization for children and adults is mood disorders. And actually, they're both very similarly prevalent. But then if we go over to the left and look at children, the second most common reason for hospitalization for autistic children is actually epilepsy. And then looking down the list, we have two more mental and behavioral conditions. So we've got autism, and then we also have disruptive impulse and conduct disorders, two things that should be addressed within primary care. Down here we have asthma, and asthma is definitely a ambulatory care sensitive condition. So one of those conditions that should be managed within primary care and not lead a person to the hospital. I also want to note this high rate of asthma. I think I said autism. Did I? I meant to say asthma. I also want to note this high rate of asthma because, as we saw before, we have these disparities in asthma based on race. So Black children were twice as likely to have asthma as white children and children of another race and Hispanic children. And we also see the disparities in access to care based on race and ethnicity. So those things are all connected. All right, so then if we go over to look at adults, we see different conditions pop up, which makes sense based on the nature of disease and disability. But the third most common up here for autistic adults is schizophrenia. So about almost 10% of adults are in the hospital for schizophrenia. Epilepsy, again, makes the list, as well as autism is up here, but not quite as high. Okay, so providing better primary care. I've shown you a lot of information about how maybe care is not adequately addressing needs, so hopefully we can talk about some things that can address that. So there's a few levers that we can aim for to try to improve care for autistic patients. One is insurance, one is policy changes, and then I'm really interested in this ongoing discussions about how to integrate behavioral health care within primary care. So just we have a little information on insurance. So about just over half of autistic children have some kind of public insurance. So either public only or public and private. And this is a little bit bigger than the number of, or the percentage of children with special healthcare needs who have public insurance. And this is important to note because if we're going to be trying to make insurance changes, Medicaid and CHIP are among the public insurance options that are represented here, and those are two important levers through which to make changes to how care is provided. So then, not only the presence of insurance, but how does insurance work for the child or the adult? But I don't have that here. So the first thing we're looking at is, does the insurance cover the services the child needs for their health care? And just over half of parents with autistic children reported that it did, which is lower than children with special healthcare needs and children with no special healthcare needs, but not too dissimilar. The next thing is, does the insurance allow the child to see the providers they need? And here is a little bit better news. So 2/3 of parents reported that, yeah, their child could see the providers they needed because of their insurance, which again was lower than their peers. Then the last component here is, does the insurance allow the child to see the mental or behavioral health needs that they have? And this is less common in autistic children than are the other indicators we just examined. So just under half of parents of autistic children reported that their insurance covered the services they need for their mental or behavioral health. And this is actually also low in children with special health care needs in general. It's a little higher actually than autistic children, and it's low in children with no special health care needs. All right, so what can we do to address insurance inadequacies we see? Well, we can change reimbursement structures to value-based care models from models that are fee-for-service. We can provide incentives to practices to provide comprehensive care, including things like the medical home or care coordination. We can focus on family and patient-centered care, which is tied to better care and better care experiences. And we can provide better access to behavioral health care. All right, so I just want to talk a little bit about these concepts of care coordination in the medical home. So care coordination is the act of a provider connecting with another provider about a person's care. And that could be health providers for children. Sometimes that includes special education providers if the child's receiving some sort of health care or health management within the school setting. So it's the activity of connecting over a person's care. The medical home is a way to set up a practice where the practice is committed to providing care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety of care. And a practice can become an accredited medical home through one of several national accrediting bodies, and then this can change how they're reimbursed for their medical home activities. So we've got a little data on care coordination. So on the left here, we see using help to get care coordination. So about a fifth or about a quarter of parents of autistic children reported that they had help coordinating care in the past year, which was similar to children with special health care needs, but more than children without. But then on the right, we see a bit of a different picture because here we're looking at parents reporting that they need more help coordinating care. So almost a third reported, about the same amount reported that they needed more help, but that was about twice as much as parents of children with special health care needs and pretty much nobody of parents with children without special health care needs. And then another aspect of that is how much time do parents actually spend coordinating their child's care. So here at the top bar, we're looking at autism. So autism, parents of autistic children half of parents of autistic children spend at least some time every week coordinating care, and about a quarter spend at least an hour coordinating care. And that's a pretty big difference from children with special health care needs, where 2/3 of parents don't spend any time weekly doing that because their child doesn't need weekly care. And almost all children without special health care needs, 93%, are not receiving weekly care. So then similar activity, we look at the medical home. So about a third of children with autism receive care from a medical home. And this is a persistently lower number than children with special health care needs, which down here is at 44%. And then about half of children with no special health care needs. And then if we look by race and ethnicity, we see big differences here. So about 40% of white children receive care within a medical home compared to about 22% of Black children. So then the last sort of change at the systems level that I want to talk about is integrating behavioral health care into primary care. So I've been presenting all day about how mental health concerns are common, but they aren't typically recognized or comprehensively treated within primary care as it currently stands. But the idea is to sort of meet people where they are and start to provide better integrated behavioral care within primary care settings. But that's a hard activity, as you may imagine. And so some of the things that research has suggested are necessary to actually make this change are to invest in reimbursement changes, provide practice incentives, make sure that medical record sharing is is happening and capable of happening, and then workforce training. And I think that last one shouldn't be too surprising because I have brought that up several times already today, and I think that's a really big, important point. So this is a map of state Medicaid managed care policies that support behavioral health integration. And specifically, this is looking at children with special health care needs. The ways that Medicaid can support this is different in children and adults. So I'm just showing the child results here. But many states will rely on Medicaid managed care as the foundation for integrating care and medical home initiatives into child care within their state. And so this is an important policy lever to start making these changes. And as we saw before, about over half of autistic children have some sort of public health care. And this map really highlights how there's differences in how states are performing towards this goal already. Some states don't even have managed care policies that treat children with special health care needs. So these are the aspects of building this integration capacity that are highlighted in this map. So provision of behavioral health services within the managed care setting, value-based payment incentives, case management, publicly available data to make sure we have quality checks, data collection requirements for the same purpose, sharing patient information between providers, team care and co-location of providers, especially behavioral health and primary care, care coordination or integration, and workforce training. All right, so that's the end of the presentation of results, which is good because I see I'm coming a little close to our time, but I just want to wrap up with a few conclusions. So from this life course perspective, I've been bringing up health services and intervention can positively influence our health, just as the lack of these things can lead to poor health. We've seen that autistic people have a lot of health concerns and they need better care at all ages. So it's really important to address these concerns. And we also pointed out that race and ethnicity are associated with worse health and poorer services in autistic children. We also saw a lot of complex healthcare needs, and this makes comprehensive care really important, but it also makes it really difficult. The more providers somebody needs, the more concerns they have, the harder it is to receive this care. So it's really especially important for autistic patients. It's also important to provide more appropriate care to reduce barriers to accessing care, because this leads to better health and this reduces emergency care utilization, which is an important thing for long-term health. And emergency care is often more expensive. So in order to move this work forward, I have a few recommendations. So first, we should begin by embracing the idea that all types of health is important. I specifically say this because mental health care is a constantly overlooked portion of health, and it's really important, especially in autistic patients. We've seen these high rates of co-occurring conditions, high rates of medication use, and the need for these services should really drive the way that we inform how we change primary care. But this also includes things like dental care. So there's all sorts of health concerns that needs to be addressed in a comprehensive way. Which leads me to the second point, that we need comprehensive care at critical life stages, such as the transition to adult care. This can also be related to critical world stages. So right now is a time when people need comprehensive care, and we're all having trouble getting it because we're in a pandemic. But this really highlights important systemic changes that could lead to better primary care and comprehensive care at all times. Third, we need to do a better job of addressing the persistent racial and ethnic disparities. I've been highlighting these throughout the report, and we need to move towards addressing these and making systemic changes that make health better for everybody, and then change the way that care is provided so it doesn't perpetuate these inequities. Fourth, we need to aim for policy levers that can support integrated care. There's a lot of really important Medicaid policy levers here, especially for children with special health care needs. And these are things that could really drive some changes at the state level, not just for public insurance, but for the whatever privately insured patients are receiving care there as well, because a lot of the policies that come from Medicaid then inform primary care or the insurance received through other systems. And then finally, I want to end by highlighting the need for more data. So I have talked a lot about children in this report and in this presentation. That is by, it's not by desire. I would really love to be able to tell you some more about autistic adults and how their health and healthcare is. But we just have so much more information about children, and that's sort of a common occurrence in health data too. Honestly, we collect a lot of information about children, but we really need more information about adults to inform how we need to improve care to lead to better health. And then I'll just say again that a lot of this information came from this National Autism Indicators Report, which is up on our website. I want to quickly, these are the topics that are covered in that report. All the stuff I talked about today is covered, and then these are kind of the other topics that are covered. These are the data sources, and these data sources you saw on the slides above. We have 2 national surveys, which are the first 2, the National Survey of Children's Health and the Medical Expenditure Panel Survey. The National Inpatient Sample gave us the information about hospitalizations. And then again, we have those Kaiser Permanente Northern California results, which came from previously published research. And one of our co-authors, Lisa Crowan, was an author on much of that work. And speaking of co-authors, there's Lisa in the middle. And then I also want to note Andrew, Christy Anderson, and Lindsay Shea, who work with me at Drexel. And then Alice Kuo, who was our co-author from UCLA, and Paul Shattuck, who is a co-author from Mathematica. Squeeze these funding acknowledgements in. So a lot of this work was funded by the Autism Transition Research Project from the Health Resources and Services Administration. Newly, we are funded as part of the Autism Intervention Research Network on Physical Health, and that funding mechanism will help us move some of this work forward and focus on even more health outcomes in autistic patients. And here is a link to the report if you would like to go check it out. You can use this QR code scan on your phone or type this web address in. And I am ready for questions if anybody has any.
Wonderful. Thank you so much, Dr. Rast. That concludes the presentation portion and begins the Q&A session of today's webinar. We'll now begin the questions submitted during today's presentation. And as a reminder, you can still submit questions through the questions pane in your control panel, and we'll get to as many as we can. So our first question, what exactly is healthcare transition? Is it a formal process?
Yeah, that's a great question. So it should be a formal process, and it can start in kids as early as age 12. That's the recommendation at this point. It should involve ideally some sort of a written or at least shared plan where the provider and the family can identify the needs and the priorities of the transition. So it certainly should be a formal process that the family undertakes, and there are tools to help providers build out their capacity to provide and support healthcare transition.
All right, and our next question, should providers have more training on communicating with their autistic patients?
Yes, I'm not a provider, and so I feel like this, makes it a little harder to say this. I understand the research that suggests that they should. As a human services researcher, they certainly should. There are a lot of demands on providers, but I think that in general, learning communication methods that would apply to providers to help them communicate with all sorts of patients who are neurodiverse, not just autistic patients, certainly help their practice and help them provide better care.
All right, now my next question, I'm going to make a comment immediately after and then turn it over to you. Can you provide any resources for youth with ASD to practice self-advocacy when they do go to the doctor or dentist? That being said, the healthcare webinar that we're hosting on April 15th will discuss a healthcare toolkit for youth to use when they go to the doctors. So over to you.
Well, that's a good answer. I know that there are, so it depends where you are. So some state initiatives have created such toolkits. It sounds like there's going to be some comprehensive information about one next week. So I think that's my recommendation. Sign up for next week's webinar.
Fantastic. All right, we have time for a couple more questions. Why is Medicaid a good place to look at politics for care integration, or policies, excuse me, for care integration?
Yeah, so states often look at these Medicaid policy changes as exemplars of what insurance can do and how it can be improved to improve patient care, both from a quality standpoint and from a cost standpoint. So many initiatives for a lot of policy changes at the insurance level, but even for behavioral health integration, are piloted through Medicaid. And it's a way to sort of prove efficacy and prove that it's a good move. And then states can open those up to the larger population, and then private insurers can also choose to use those types of reimbursement models.
Fantastic. All right, so the next question. Mental health concerns seems to have come up a lot. Is there more work being done on this?
Yeah, so there is. I'm really interested in this topic, which I guess is probably why it's in this presentation so many times. So this integrating behavioral health care or mental health care into primary care, I think is a really important place to meet people to provide this comprehensive care. I know that there are several other researchers interested in this topic as well. And one of the research initiatives I mentioned, the Autism Intervention Network for Physical Health, also will have a focus on that. So I think hopefully we'll see movement in this area in the coming years.
Okay. Discuss briefly were the need for services for autistic children and the need for behavioral health services and the need for dental services. Do you have any specific data on the need for home care nursing services or the lack thereof?
I don't. And I'm not sure if I imagine that would vary by child or adult care. I know that there's some information. So, for example, some state developmental disability systems will collect information about their patient or their populations. And sometimes they'll collect information about the types of services they receive. It's sort of like a quality check measure, these reports, and they do them yearly, but it's possible that there's information there, but that would be specific to people who receive state developmental disability services. But I'm not even sure what percentages would have reported that. But I think that would be a good place to assess that type of information.
All right, we have time for one more question for you. Thank you. My nephew has not yet been diagnosed. Is this difficult for most primary care providers?
Yes, and I would say that, so sort of a typical trajectory would be that a primary care provider may either have done a screening or been notified by the parent or by somebody else in the child's life, which could include like early intervention or schools, teacher, something like that there's a potential concern. And then sometimes the primary care provider will try to facilitate a referral to somebody who can do a diagnosis. So almost never will a primary care provider provide a diagnosis. But they are a good lever or a good tool to approach trying to get to the next person that can help you with that. So definitely concerns about that can be brought up to the primary care provider.
Thank you so much, Dr. Rast. That's all we have time for today. Thank you everyone for joining us. If you found today's event helpful, we encourage you to register for OAR's next webinar event about mental health and suicide prevention, which will take place on Wednesday, April 7th at 2 p.m. Eastern Time. We also have another event as part of our April Health series on April 15th at 2 p.m. Eastern, featuring a healthcare toolkit. Check those out on OAR's website or check out your chat pane right now. Once we close out the event, you'll receive an exit survey. We would appreciate if you would complete that and share your feedback. Everyone will receive a follow-up email with a link to today's video recording and materials within the next week. So on behalf of the Organization for Autism Research, thank you for joining us this afternoon and have a great rest of your day.